Have you ever noticed a bulge in the groin that comes and goes? Especially when coughing or lifting. That's often an inguinal hernia. And while many are benign, some can actually become surgical emergencies. In this video, we'll break down how inguinal hernias develop, the different types, the key anatomy surgeons should care about, and when they become dangerous. And lastly, make sure you check out the end because we're going to talk about how to fix it. How do you choose between open or minimally invasive approaches? Let's go ahead and get started. So let's start with the first question. What is an inguinal hernia? An inguinal hernia occurs when an abdominal content, usually fat or sometimes your gut, actually protrude through the weakness of the abdominal wall or in the groin. The weakness exists near the inguinal canal, a natural passageway where structures like the spermatic cord in men or the round ligament in women passes through the abdominal wall. Why is this so? So for men, when we're actually born as an infant, the testicle actually descends from the abdominal cavity through the inguinal canal into the scrotum because the hot temperature will actually boil our testicles, which is not good. And so to maintain fertility, it slides out. And what should happen is that area where it passes through should actually close around the structures that supply the blood vessel and duct to the sperm. However, in some cases it doesn't, and hence a type of inguinal hernia occur, which is an indirect. The other types of hernias include a direct defect, wherein this is an acquired abdominal wall hernia weakness. It actually goes through Kesselbach's triangle, which is bounded by your inferior epigastrix laterally, the rectus medially, and the inguinal ligament inferiorly. This triangle then is a point of weakness that when people actually have increased intra-abdominal pressure in, let's say, coughing, heavy lifting, constipation, pregnancy, or sometimes obesity actually may aggravate and hence cause a direct defect in the hernia. As we talked about, there are two types of hernias, mainly the indirect and the direct defects. The indirect is going to be lateral to your inferior epigastrix, and then the direct defect travels to Kesselbach's triangle, which is medial to your inferior epigastrix. There are other defects in the inguinal region, which you could also notice when you do MIS surgery. That is going to be a defect through your femoral canal, which is a femoral hernia, or an obturator hernia. Around the abdominal wall cavity, you'll also sometimes see a Spigelian hernia, which is going to be a defect in the linea semilunaris, slightly just above the inguinal canal. Now let's actually move to signs and symptoms. The common signs and symptoms include mostly a groin bulge that worsens with standing or straining. Other symptoms that you actually have to know is when something gets trapped in the hernia or has been incarcerated, sometimes this affects the bodily function. So let's say your guts actually gets trapped in there. It may affect your bowel function to the point that you can actually get an obstruction. Sometimes people can actually get bladder symptoms, and that's very important because when we do operate on them and there is a bladder involvement, if there is suspicion, we usually tend to investigate prior because those bladder hernias can actually have a higher risk of injuries, and knowing before you operate is actually very helpful, especially when the injury risk is up to 10%. So, when does it become an emergency? This is very important. An inguinal hernia becomes an emergency when we either have concerns of strangulation or acute incarceration. Both are actually going to be similar in concept. However, strangulation is worse because that means there is going to be a higher risk of ischemia or perforation. It's like choking something in that narrow canal and to the point that it's actually going to die. And so we don't want that one. The lesser complications from the hernia, the better it is for the patient, and intervening early may actually prevent it. Or if not, you may actually fix the problem before things get worse and the patient gets more sick. So how do this present? Well, the most important thing is, number one, both are not going to be reducible. However, if you qualify incarceration, if it's chronically incarcerated, like those very large hernias, you don't necessarily need to fix them emergently. However, if there are signs of obstruction, or there are signs of concerning of strangulation, and how would that present? Well, if there is strangulation, there was probably going to be some form of obstruction or some form of ischemia in which there would be pain, tenderness, and a lot of inflammatory tissue surrounding that area. And doing a CAT scan may actually be helpful to evaluate and delineate both this through imaging. This requires emergent surgery. Now lastly, now that we've actually discussed what a hernia is, what the types of hernia, the key anatomic factors, and when to intervene, now we are going to talk about the approach. So how do we fix hernias? So there are going to be two types of repair. One is going to be open, the other one is minimally invasive, which can be done either laparoscopic or robotic. Majority of the repairs nowadays are actually with mesh. Why is it so? Well, when you actually do tissue repair, that means you're reapproximating layers of tissues in which there is a congenital weakness. That means the tissues are actually not normal or as healthy. And so when you actually suture things which are not healthy, there's higher likelihood that there is a failure rate. So how does mesh work? Imagine a scaffolding of weaved permanent fabric that is then laid. And this allows tissue ingrowth and some form of inflammatory reaction that helps actually support the structures that we are trying to block from things passing through. And that's how it actually helps in preventing things from recurring. So how do we choose between open or MIS? Basic gist, if you're doing bilateral, that is going to be better served with minimally invasive because you can approach both sides with the same number of incisions. If you've had previous surgery, let's say somebody had an open surgery and there is a recurrence on the right groin. Well, approaching it through an open surgery again is actually higher risk because you can actually injure the structures from all the scar tissue there and complication is going to be higher. So what we do in that aspect is do what is opposite. We actually go minimally invasive. Lastly, one of the major differences between open and MIS repair is you can't do MIS repair unless you have general anesthesia because it requires complete relaxation of the muscles in order to perform pneumoperitoneum. On the other hand, you can do either local anesthesia or block with regional anesthesia for open surgery. So I hope that actually clarifies the things about a hernia. If you actually guys like the video, please click the like and subscribe. Type your questions in the comment. What your thoughts are, is open versus MIS, and then check out the other videos we have. And